Our next talk will be about Stevens-Johnson syndrome, how to avoid long-term sequelae by Dr. Stephen A. Watson.
Thank you very much. And as this is my last talk, I'd like to also pass on my gratitude for having to be able to present at this meeting, and to the organisers and to everyone for such a great meeting. I think Dr. Hunush, Professor Hunush, expressed very well the gratitude, and I'd like to echo that. Okay, so Stevens-Johnson syndrome, look, fortunately it's not that common. And as we know, it can be associated with antibiotics, antiepileptics and non-steroidals. And there's both cell-mediated and antibody immunity and genetics implicated, this has implications for its management. I always wondered why it was called Stevens-Johnson syndrome, so I looked it up, and it was a bunch of, two paediatricians, one named Stevens and the other Johnson, who'd first described it in 1922 and published it. Okay, so there's an acute phase which usually resolves in about 2 to 4 weeks, and this is typified by conjunctivitis, anterior uveitis, corneal ulceration and conjunctival ulceration. And then it can go into a chronic phase, and this is where you see cicatrization of the conjunctiva, dry eye, and eventually you can get limbal stem cell failure. Now, in the acute phase, you have a lot of T-cell mediated type 4 hypersensitivity, and you need to control this rapidly to minimize the potential for this to cause scarring in the future. The chronic disease is more complex, and it's probably not solely T-cell driven, and so there you need a broader spectrum anti-inflammatory treatment. And sometimes, because this is a chronic scarring condition, you can still get progression despite control of the inflammation. In the acute phase, you need a multidisciplinary team. If the cases are very severe, the patient will often be admitted to an intensive care unit. Obviously, the first thing to do is withdraw any agent that might have started the Stevens-Johnson syndrome, and then supply supportive therapy such as fluid, electrolytes, nutrition. Now, in the acute phase, within the first 4 days, there's some evidence that corticosteroids and high-dose immunoglobulin may lead to better outcomes. But the results on this in the literature are conflicting. Because the patient will be managed in a multidisciplinary setting, this is a discussion, and they'll often have skin manifestations as well. This is a discussion with the physicians that's looking after them, and in the intensive care unit specialists, whether this therapy might be appropriate. There's some newer agents that are being considered and have been trialled in this disease, but the evidence for their use is still emerging. And this includes things like infliximab, entacicept, plasmapheresis, cyclosporin, and TNF-alpha inhibitors to act on the scarring. So acute Stevens-Johnson syndrome management from an eye point of view includes careful daily conjunctival hygiene. You can give topical preservative lubricants every couple of hours, and prophylactic antibiotics for the corneal and conjunctival ulceration. There's some evidence that topical steroids, such as preservative-free Predsol if the symptoms are mild, and dexamethasone if they're more severe, can be used to help reduce ocular surface damage in the future. And if the patient is in ICU, make sure their corneas are protected, because corneal exposure can occur. Now, once you've got past the acute phase, you need to think about how do we prevent progression from here. And progression occurs through a combination of effects. And the surface failure or the limbal stem cell failure typically occurs after 2 to 3 years. And along the way, you can have these recurrent episodes of inflammation, such that the disease can be indistinguishable from OCP, which we've just heard about. So this is how the condition can progress. So you have the underlying immune-mediated inflammation. You can then develop, as a result of the disease, ocular surface disease. This includes things like trichiasis, entropion, blepharitis, dry eye, persistent defects, and limbal stem cell failure. Once you have this, you're then at risk of infection. You then try to treat the infection, treat the disease, you can get toxicity. And all of these together can then lead to surface failure and corneal blindness. So we often need to, in the chronic phase, we need to also use some degree of immunosuppression. And this is because of the chronic ongoing inflammation. And again, this will be managed with a multidisciplinary team, and there's a range of immunosuppressives that might be used, and the decision will be made by the treating physician. But the basic approach is to step up and step down, and this is similar to OCP, where you start with sort of the weaker immunosuppressives and you move up to ones that are better able to control the inflammation if it's persistent. Once you have the systemic inflammation under control, you then need to move to treating some of the ocular surface disease or manifestations. And so one of the ones that can cause a lot of damage is trichiasis and entropion, because the lashes turn in and damage the cornea further. During the acute phase, you can't, while you've got active inflammation, surgeries can't go forward because of the risk of making the scarring worse. And so you may need to temporize, and here you can use things like that temporary tarsorrhaphy with a bit of tape. But ultimately, patients will need to have the lids repositioned to move the lashes away from the cornea. And that is a patient that's had this lower lid retractor plication and upper lid lamellar reposition. You need to then, once you've done this lid repositioning, you may still have some misplaced lashes that you may need to treat individually or with lid split surgery and cryotherapy. Blepharitis needs to be managed, as this can cause further inflammation. Again, the typical ways you manage it with lid hygiene and cleaning. Doxycycline is useful for posterior lid margin disease. And for dry eye, a talk on management of dry eye is a talk in itself, so I won't go into the details here, but the highlight here is to use unpreserved drops and use them often. You can consider punctal occlusion, but only if the blepharitis is being controlled. Sometimes these cases will have scarring of the puncture anyway, and serum drops can be used for severe cases. What about persistent epithelial defect and surface failure? Well, here you follow the sort of therapeutic stepladder or typical stepladder approach that you would have for managing this for a range of conditions. And excluding infection is key, avoiding toxicity by using preservative-free preparations, treating any coexistent disease. So that's a patient before and after treatment. You then, over time, once you've healed the surface initially, you then need to move into ensuring that the epithelium remains stable, ointments, Botox, contact lenses, tarsorrhaphy as needed. Autologous serum drops also useful for healing defects, and for some cases, amniotic membrane grafting and lamellar grafting once the inflammation has been controlled. And in some cases, you may need to look at doing stem cell or buccal membrane graft treatments. So once you've worked on improving the ocular surface and trying to stop progression, you can then move towards improving the vision. And this may include a range of contact lenses and in some cases grafting or keratoprosthesis. So in managing these patients and getting the best long term, you need to place realistic limits on the patient's expectations, as treatment can be difficult and it can be hard to get good results. Damage limitation is where you should be at, less is often more, and you need to agree the treatment strategy with patients. You need to remind them to come if there's been any deterioration, as there is a big risk of infection, and educate physicians as well about their ocular needs. Patients often need social support. Thank you. For the future, though, we need diagnostic biomarkers so we can find out who's actually susceptible to this condition, so hopefully they can avoid it. If we understand more about the genes, genetic therapy may be an option. In children, it appears to be a range of these conditions that are given this broad term described by the paediatricians in 1922. So there's probably different manifestations of the disease that we need to understand in order to develop targeted therapies. So it remains a therapeutic challenge. We need everyone involved, need to diagnose promptly and institute management, The chronic management is complex and we need high quality evidence and new therapies. Thank you.
Thank you very much, Dr. Watts.